Okay, fantastic. So we can see people making their way into the webinar. It's so much easier online when you don't have one doorway that everybody needs to kind of cram through to make their way into the room. It's very much everybody's already in their own seats, which is great. Great. So we can see everybody making their way in. Brilliant. So hello, everybody. Welcome to today's webinar in association with the Digi4MSK project and the European Pain Federation, EFIC. This is a second webinar from this collaboration and the 10th in a series of webinars from the Digi4MSK project. You can check out those in the resources that we'll share a little bit later. So I'm going to go and give the floor to the coordinators of that EU Erasmus Plus funded project in a moment. But today we're joined by several panelists who you might be able to see very soon to discuss how pain-related distress differs from other psychological constructs, why it matters for short and long-term outcomes, and how communication plays a central role in all of this big picture. As always, we have the absolute privilege of being joined by some world-leading experts in this space. And we will get an introduction from our panelists in just a moment. But first of all, thank you all for joining us. And I'd like to just very quickly take this opportunity to just explain a little bit about this webinar, how it's going to go, and how you can make most of everything that we have today. So you are joining us, of course, on a live webinar. Therefore, it's a great opportunity to engage with our wonderful panelists here today. It's not often we have a chance to engage with leaders in this space, so I encourage you to get involved, of course. You can do this by using the live Q&A function at the bottom of your screen. Here you can submit questions or thoughts that you might have. You can also do this anonymously if you wish to do so, which is quite nice as well. Unfortunately, as normal, due to the numbers, we aren't able to have people ask over the microphone. So please get your questions in the Q&A function as soon as possible. We'll be answering these after the presentations. And what tends to happen is that we get a large flurry of questions right in the last 3 or 4, 5 minutes, meaning that many go unanswered. So we have a little bit more time than what we normally do on our webinars here at EFIC, but still try and get your questions in or comments in ASAP. And there's also a chat function that you can use for general comments as well. So, as usual, we'd like to take this opportunity to hear from you right now. So please let us know, pop into the chat where you're joining us from, perhaps a little indication to your background, medical professional, researcher, clinician. If you can, answer the poll that we have coming up on screen to let us know your background as well. Whatever it is, let us know in the chat and come and say hi. Come and say hi. So finally, a reminder that this is also a recorded webinar, so you can access these discussions at a later time if you wish to do so via the online resources for the Digi4MSK project and, of course, the EFIC Academy website and YouTube channel. Brilliant. So we can see if everybody come and say hi. Great stuff. Hi from Exeter, Blackpool, Leeds, Denmark, Nottingham, Northern Ireland, Berlin, Chile. Welcome. Thank you so much for joining us. And we can see some stuff coming through on the poll. I think once we complete the poll, I'll be able to see the results. I can't see the results right now, so God knows who's here. But please let us know in the poll. Answer it if you can. Okay. Let's go on to our first speaker, shall we? Actually, before we do that, let me just see if I can get the results of the poll. If we can see them, brilliant. I can now see them. It's great. So 74% clinician. We have about a quarter researcher and one person living with pain, which is great. A great representation. So thank you so much, everybody, for joining us. So I'd like to hand it over to our first panelist, Dr. Victor Dominic Garcia, who is going to give us an insight into the Digi4MSK project, which sits at the center of patient-centered communication in MSK pain management. Victor, thank you so much for joining us. It's over to you. Welcome.
Thank you very much, Nathan, and thank you, Tamar, for accepting this invitation. Well, I'm just going to take 3-4 minutes not to introduce again the Digi4MSK project because probably many of you already know it. So I'm going to provide value with within these 2 minutes about the resources that are already available for not only clinicians, but also patients living with pain. For that 1% that has it has joined us today, one person that has joined this webinar. I hope that you are seeing my screen properly. Just a quick reminder, Digi4MSK is a European alliance with different companies, vocational education, universities, and also the EFIC. This, as Nathan has just said, is the webinar number 10th. But you have to think that we have already other webinars that are already available and free access on our website, in which we have covered different topics related to musculoskeletal pain, health literacy, and self-management, such as, for example, how to support self-management in low back pain patients, how to improve communication, how to implement digital practice, etc. So all of them are available. So I invite you and encourage you to visit our website, in which you will be able to find them. Another resource that has just been released is a book of good practice, one for healthcare professionals working with patients with musculoskeletal pain, and another book of good practices for people living with pain, in which you can find real examples described in vignettes about how to, for example, prepare consultations with clinicians, how to implement self-management principles in daily life, how to understand the results of scans, etc. Many things that are very, very useful, hopefully, for patients, but also for clinicians, about how to deal with difficult situations with patients, such as, for example, patients struggling to adhere to physical activity, or how to make pain less impactful, etc. So the links of these resources are going to be, if I'm not wrong, they are going to be written down in the chat. So it is either basically our website, digi4msk.eu, but also this open access repository, which is Zenodo, which is what you are seeing right now. But we will, as I said, write down the link in the chat. Another resource is the courses. It is something we are starting right now, online courses. We are going to have different editions, but they are for free. So we encourage you to sign up or to enroll, to register in these courses, and you can do it with this QR code. They are free. It is just that you will have to find the time that is best for you to take the courses. And they are about, of course, how to improve health literacy in patients, how to implement self-management in the clinical practice. But for those of you who are already patients, we have, again, all of our materials have two versions, one for healthcare professionals and another one for patients. And we have specifically adapted our outputs to these two populations. And yeah, you have other resources such as the two systematic reviews about what practices regarding self-management are effective, which is two systematic reviews that are about to be published, but the summary of them are already on the webpage. And also a very interesting report about how people with pain and also healthcare professionals behave on the internet when it comes to find information about musculoskeletal health literacy. What type of resources do they find? How often do they go online for finding information? Whether or not this information is reliable, etc. So that's all. That's it on my side. Thank you very much, Nathan. And again, Tamar, thank you. And see you later in the question session.
Fantastic, Victor. That's brilliant. Thank you so much for sharing that. Of course, lots of resources. I think the important part is that there's also resources for people with lived experience of pain, all manner of people, which I think is really important. We do have one very quick question, if I can pose to you, Victor, before we move on to Tamar. Mia said in the Q&A, which of course everybody needs to use today to send us the questions, have the workbooks been translated to different languages? And if not, do we need any help with that? How is the translations going?
It's very, very good questions. They are already translated to the languages of the countries of the partners we have in the consortium. So they are available in Danish, in Spanish, in English, in Italian, and in German. Okay, but if the person who has asked is interested about translating it to other languages, we are more than welcome to collaborate. And of course, we think that it might be of value. And of course, European Commission favors that, and it will be very happy that we demonstrate to them that we have translated it to other languages. So just you can contact us, and we will figure out how to collaborate. So thank you for your offer.
Fantastic, brilliant stuff. And obviously lots of resources. Please go and explore those, guys. Again, many different languages, many different perspectives, and there's a lot of work that's gone into those. So feel free to explore those. All of the links are in the chat as well. I think there's a comment from Emma as well. Victor, I don't know if you're able to answer that in the chat so we can move on to our sort of main presentation today. So just a quick reminder that you can submit questions and comments in the Q&A function, just like Maya did there, or you can use the chat function. You can also do it anonymously as well. Okay, so now I'd like to hand it over to Professor Tamar Pincus, who is a psychologist and world-leading expert in chronic pain. Before we start, Tamar, I just want to take this opportunity on behalf of EFIC and the Digi4MSK project to thank you for taking time to speak to us and be with us today. I think this is a super interesting topic, and we've clearly got a lot of people who are ready to engage in a deep discussion. There's going to be lots of opinions, and I think it will be a good platform to discuss, right? So thank you again, and I'll hand it over to you. Thank you.
Absolute pleasure to be here. Please wave at me, Nathan, to say that you can hear me.
I can.
You can. Okay, I will share my slides. At least I hope I'm going to share my slides. There we go. Am I sharing?
Absolutely. Great stuff. Thank you.
All is good. Okay, absolute pleasure to be here today. And so exciting seeing all those countries coming up on the screen. This is refusing to move for me, which is annoying. There we go.
There we go. We've got some movement. Great.
We've got movement. Okay, conflict of interest. First of all of the research that I'm showing you now has been funded, and I particularly want to thank Arthritis UK because they funded and are still funding a big set of projects around this. I also want to tell you that I carry out consultancy activity teaching psychologically informed practice. And again, how lovely to see all those countries, because I have done these courses now in the majority of Europe, Denmark, Sweden, France, Spain, I could keep going, Switzerland, South Africa. But I was particularly excited to see Chile because I still have sweet memories from doing a course in Chile and the warmth and friendliness that you all showed me. Two other disclosures. One of them is I live with intermittent musculoskeletal pain. So very few of us are actually just researcher, clinician, or person living with pain. We all tend to have all of those. And the last sharing here is I'm very opinionated. So I welcome you to challenge me on anything that I say today. Here's the problem we're all dealing with. An awful lot of people living with pain are also distressed. And what I mean by distressed here is a combination of low mood and worry. So if you like, a combination of depression and anxiety. And very often, if you read about this, or if you read case notes, you'll see this referred to as depression. And it's described as a comorbidity. So you're living not just with pain, but you're also living with this psychiatric problem called depression. And possibly these two need to be solved separately. What I'm going to argue is that this actually is not the case at all. It's not a psychiatric morbidity. It's not abnormal, and it certainly doesn't need to be dealt with separately. So the research looking into depression in the context of chronic pain often involves using questionnaires, and you're probably quite familiar with these questionnaires. The HADS, the Hospital Anxiety and Depression Scale, the BDI, the Beck Depression Inventory. It's a whole set of questions you give to people, and they self-report. And these questionnaires have items which include how well are you sleeping? How much energy do you have? Have you had changes in weight or in appetite or in libido? And also your ability to make decisions. And of course, low mood. And my argument is that those questionnaires are contaminated because, in fact, it is impossible to know whether people said, yes, I have difficulty sleeping, I have low energy, my weight has gone up or has gone down. I find it really hard to make decisions and my mood is really low because they have depression or because they have pain. Because of that, our research is a mess. So a long, long time ago and far, far away in London, I got together with an amazing researcher called Amanda Williams, and we wrote this paper. We're talking about 1999. Yes, that's how old I am. And we were really interested in this idea that we are trying to treat chronic pain and depression as two separate entities, but actually we don't understand, we don't have good models to understand what this thing is, and we certainly don't know how to measure it. I've put QRs along the way for those of you who like reading the original, but it won't tell you anything that you don't know already, is my suspicion. And here we are many, many years later, going back to the same story. So in this case, my research team went out to talk to people living with pain and to also talk to their general practitioners who are trying to deal with the same thing. People turning up and saying, I can't live like this. My suffering is extreme. I'm not functioning. My mood is down. I'm not looking forward to things. I find it hard to make decisions. And what we did is we interviewed people and we talked to them. And they said to us, this thing, this pain-related distress, it's not depression. It's not what they understand as depression. And they don't like the label very much. It's not abnormal. In fact, I've come to argue that if you are living with severe chronic pain, it would be very abnormal for you to be perky and happy all the time, because the impact of chronic pain on all aspects of life is quite severe. This level of distress, of worry and of low mood and of a sense of sometimes guilt has a huge impact on life. None of us know what to do about it. The patients are starting to develop some ideas, but they have said to us that their clinicians really are lost. And the clinicians, these are general practitioners, said to us that they are very confused, that they don't like giving it a diagnosis of depression, but they have nothing else to put in that box. They don't like referring to a psychiatrist, but they don't know who else can help. For the patients, it seems linked, this low mood, to things that they've had to give up. And the GPs simply feel helpless. And actually, every other healthcare provider I've talked to, be they physios, GPs, surgeons, have told me the same thing. We don't know what to do about this low mood and distress in chronic pain. So I've tried to develop a framework which I am sharing with you, which divides distress into three different components. And this is not necessarily completely evidence-based because we haven't conducted trials on this, and I'll show you why it gets difficult in terms of the evidence, but I think it's helpful from a clinical point of view. So I already said that living with chronic pain involves a level of distress. It would be really surprising if you didn't have that, because there is real loss. There are things you can no longer do. There is justified anxiety about the future, financial future, future in terms of your relationship with your body, your ability to do activities, your ability to care for people you love. And recognizing these problems is something that some clinicians do extremely well on a regular basis. And then there's a question of having the conversation about change. What can you no longer do? What can you do? What can you change to feel better about yourself? What can you adjust? And I've put at the bottom some quotes from interviews. So patients say, it just breaks my heart that I can't run anymore. I used to run all the time. It was so important to me. Or I honestly don't know how we're going to manage financially because I can't have a full-time job anymore. And there, I think the role of the clinicians is to acknowledge first of all, to acknowledge and validate the fact that a real change, a real difficult change is on the table. Discuss it and maybe use some effective problem-solving techniques in order to come to solutions. But then there's also the situation, which I think a lot of you are familiar with, where patients come up with distress levels that are unhelpful to them. And they find it so hard to move further and even to move further with you along the journey to rehabilitation and management because they're so stuck in this place of feeling that they can't deal with these emotions. And when they talk about them, these emotions get bigger and bigger the less they're recognized by the people around them. And they start generalized to everything in their life. And they have this non-specific quick flare-up to anger and resistance to help, not because they don't want to help, but because the emotions overshadow their ability to use the help that they're given. And that's where you get statements such as, my whole life is destroyed. Notice here, the whole life, that's the magnification. Nobody seems to care. That it's starting to overshadow everything. And you get this game that humans play with each other, and we all play these games, not just patients. We play them with our friends, with our loved ones. We all play yes, but. And that's the game in which you end up offering more and more solutions only to hear why people can't use them. Have you tried this? Yes, but, and there's a reason why we can't use it. And what I've seen in my work is that one of the most effective ways of dealing with this yes, but sticky place is to validate the patient's emotions. That's not necessarily to validate their behaviors if those behaviors are not helpful to them, but to validate the fact that it is hard and that they have gone through a lot. And I could do a whole other 60 minutes just talking about validation, but I won't. Another thing that is useful is to use cognitive behavioral approaches. And I've put here a line under approaches because we have a lot of people with us today who are not psychologists. Cognitive behavioral therapy is a complex and difficult thing to do well. And I think you need a lot of training and supervision and mentoring in order to get all of the package that is involved in CBT and use it effectively. But some of the ideas in CBT can be used effectively by anyone who is working with a patient. And many of you are using it even if you don't call it CBT. We'll look at some of these ideas around reactivation or trying to catch your thoughts before your thoughts affect the way you behave. And if you can't deal with it, consider referral to somebody who does use this on a regular basis. And then we've got this animal called depression. And you know that somebody is truly depressed when you sit and talk to them. It feels like the energy in the room is being sucked out. There is a sense of deep self-denigration, not liking or loving yourself, guilt, shame, and extreme hopelessness and helplessness. It is often perceived and experienced as an experiential and existential state. And these are big words. But what I mean by that is it is as if the entire world is a negative place and it always will be. And the sense of helplessness is it can't change. We are stuck in this black place. It's all my fault. I always ruin everything. I ruined it in the past. I will ruin it in the future. I'm just so useless. There is no point trying. And in these cases, this extreme sense of lack of any light in the room or in the future room, referral is indicated. And the other thing that people feel it's very difficult to deal with is the idea of gently exploring suicide and self-harm tendencies. And I think that what we have learned, and there is a lot of evidence for this, is that that exploration is needed, even if you're not a psychologist. It is a risk minimizing procedure, and many, many countries have got guidelines around how to do it and the need to do it. And if you think that that's something that you don't want to engage with, please read around this because I think that it is extremely important. So Pain distress and depression, they are different. Pain distress actually reacts to fluctuations in pain. This is a really important point for clinicians, because what I'm saying here is that you can see how mood follows the pain level. When the pain goes, the mood improves. When the pain comes back, the mood reasserts itself. That is not the same with depression, with clinical depression, which tends to be steady over time. It doesn't fluctuate a lot. This also means that historically, if you ask patients, they're able to say to you that this tendency to have low mood started even before they had the pain, if they are suffering from clinical depression. So when the mood responds to pain, we start suspecting that this is pain-related distress, not depression. Another thing we've noticed in our research is that if you ask people who are distressed and suffer from chronic pain about the future, they are able to imagine a better future. If you say, if I waved a magic wand and took away your pain, what would the future look like? They go, oh, it'd be amazing. Whereas with depression, clinical depression, it is very hard to get to a place where the future could be brighter. And although we have guilt in people with pain-related distress, it is operational. It is about what they are not able to do. I can't do my job and other people have to pick up for me. I can't pick up my 2-year-old. I can't be a good mom. While as the guilt in clinical depression is often what I call existential. I feel guilty about everything. I feel guilty about wars. I feel guilty about the pain in the world. I just feel like I'm somehow a bad influence. So pain-related distress may be more appropriate to those where the pain is functioning primarily as an interruptive stressor. It's something that stops us doing what we need to do. This is a quote from a paper that is just about to appear in Pain, so I couldn't give you a QR, but do look out for it. It's from our team, and it is trying to encompass exactly what I'm telling you in this webinar today. So how is it different? What is happening in the head? We are now about to move into psychology. So warning, warning, this really is talking about the mind. Pain interrupts our ability to plan for the future. It interrupts our immediate goals, what I'm trying to do right now, and it interrupts our thoughts, our ability to carry out a passage of thoughts towards somewhere where you want to go. It is sticky. It keeps us thinking about it. We worry and we ruminate. Our perception is affected. The way we think about our past, our recall, the way we pay attention to things that are happening now. It also involves an overwhelming need to share this pain with others. And much of this activity inside our mind is not in our control. It is non-volitional. And some of it we are not even aware of. We are not even aware that our brain is scanning our body and finding ambiguous sensations, interpreting them as painful, and then telling us to behave in certain ways. The mind interprets the world. And these are cognitive principles that can explain what is happening in pain distress. So the first one is all of us, not just people with pain, process the world through a filter. We actually don't see the world as it is. We don't look at information the way it exists in the world. Our brain filters it. And the most important thing that controls that filter is anything relevant to ourselves. If we hear our name across a crowded room where everybody is speaking, we will turn our attention towards the person who said that word. Any information relevant to us has got to take precedent over everything else. It's an evolutionary function, really. And we also select information that evokes our emotions. Anything that is fearful or invokes worry or anger or makes us happy or excited, we will pay more attention to that. So we sift stimulus from our environment all the time, and only some of it gets into our conscious processing where we can decide what we are going to do in the future in reference to the world around us. So we develop biases. Now, it could be that chronic pain biases us to select information which is relevant to the pain, and that in turn makes us more worried and more distressed And being more worried and more distressed means that we select more features from the environment, and we get into a really vicious loop, vicious and negative loop, in which our world becomes associated with our pain. And I've brought you an example of an experiment that we use to evidence these kind of biases. So I know this looks complicated, but it's really not. What you've got at the top box there, CPP, chronic pain patients. That's a group of people who we sat in front of a computer against control people, people with no pain whatsoever. I particularly like using in these experiments, asking people to participate who use a lot of pain language but are not in pain themselves. So people like physiotherapists or osteopaths, etc. And then you show them words like, does this describe you? Or does this describe your best friend? Self and other. And the words that you show people are made from certain categories. So we have words showing that are pain stimulus. Does this word describe you? Aching, hurting, disabled. But you also have words that are really typical to depression. Does this word describe you? Unlovable, unlikable, shameful. And then we might have a whole bunch of control groups. And we let people sit through this and just go, yes, it does, no, it doesn't. And in the end, we suddenly say to them, now write down as many words as you can remember from all of the words you saw. And that allows us to see what they remember in terms of biases. There's lots of experiments looking at this, and here are some of the main features that are found. So recall for people living with chronic pain is biased towards pain-related words, aching, hurting, stiff, and negative health words, disabled, ambulance, but only when they're processed in reference to the self. So exactly the same words, if they're processed in reference to somebody else, that will not register. That is not important. It's in terms of the self. And it's only in chronic pain patients who are also distressed, who are also in low mood, and those who don't have a diagnosis, who don't know what's happening with them. And this starts looking really interesting. This tells us about a vulnerability in the way that we process environmental stimulus and physical stimulus. A long, long time ago, I wrote a paper with Stephen Morley, the absolute great late Stephen Morley. And what we looked at is all of this experimental evidence, and we suggested that what happens is an enmeshment. In most people, we have a set of information, experiences, ways of encoding things around the self. It's a very simple, rough way of thinking of what happens in the mind in terms of information encoded in reference to the self. So I might have female, psychologist, brown hair, but I also have a set of information encoded in terms of pain, aching, hurting, injections, and in terms of illness, fever, ambulance. And those schemas just exist in our mind. But when we're living with chronic pain day in, day out, those biases serve to enmesh that schema about the self with the pain schema and with the illness schema. So now I'm not a woman psychologist with brown hair. Now I'm first and foremost a person living with pain, with the threat of disability. That's who I am, not just what I am. So I hope you agree that pain-related distress is starting to look like it really matters. It looks like it involves this automatic and thoughts that come back again and again, that become habitual, and they're associated with everything, because when I am a person living with chronic pain, stairs remind me of chronic pain, doors remind me of chronic pain, chairs remind me of chronic pain, my work reminds me of chronic pain. It becomes enmeshed in who I am. And it can even maintain and provoke new pain experiences. And the result is that I will withdraw from work, from social engagements, from walking through that door, walking up those stairs. Pain-related distress is a normal response to pain. It's not a comorbidity. It's not a psychiatric disorder, but it has huge implications for well-being. So what can we do about it? Well, we could give people antidepressants, right? Turns out we've done a huge Cochrane review on antidepressants. Some of you might have read it. It was on all types of antidepressants in every dose for every type of chronic pain. And one of the things we found is that we don't know whether antidepressants help the mood of people living with chronic pain because they are excluded from the trials. We also know that patients don't like taking antidepressants very often and they struggle to come off them. But a ray of sunshine for duloxetine, and only for duloxetine, there is evidence that if you prescribe it in typical dose, which is about 60, it does have a small to medium effect on pain. But as I said before, we have no idea whether it has an effect on mood because the people are excluded from the trials. So we give them psychological interventions. And here too, I think there's a place to go. There's a way to go further. So CBT is effective, yes, but it's hard to get the whole CBT experience with a clinical psychologist because it's expensive. There's not enough clinical psychologists, and it's not always acceptable. Some of the principles are not acceptable for people. And sometimes it is offered in such a diluted way that it has very little effect. The messages that patients have told us they don't like are ideas around the word catastrophizing. I don't use that word anymore. I think it's very judgy. Catastrophizing suggests that your worries about the future are exaggerated, but actually the worries about the future, if you're living with pain, are not exaggerated. They're very rational. And dysfunctional beliefs has also got a label on it, hasn't it? That something's going wrong. We've got a whole bunch of new interventions at the moment, which everybody's very excited about. Cognitive functional, pain reprocessing. And if you look at what's new about all of them, they're very individualized, they're very catered to the individual. They're very educational, lots of neuroeducation in them. They're all about activation, physical activation, reactivation, and the offer of hope, the offer of being able to cope a lot better. And often they come with an offer of cure. I will take this away from you. All of them work to reduce pain and improve function and hope that that will have an effect on mood. They do not at the moment try and affect mood themselves. So current interventions, these are the messages we give for people with musculoskeletal pain. And I think they'll be familiar to many of you. Try and manage your pain. Increase your physical activity and do your exercises, but pace yourself. Don't do too much. And try and reinterpret these negative thinking patterns that you've got and try and be aware of catastrophic thinking. So this is what we do. Whatever else you do, you must stay physically active. Well, I am one of the very annoying patients who thinks that squats and lunges were given to us by the devil, and I will not do them. So staying physically active can sound like a punishment to me unless it's said to me in a very particular way. Patients have told us that talking about pain actually makes them feel that pain is even more ingrained in the way they think about themselves, who they are. It enhances enmeshment. When they're told to manage their pain, it makes them feel like they need to think about their pain every minute of the day. Catching their automatic thoughts mean they have to stop doing what they're doing in order to catch that thought about pain, so they do even less. And above all, this constant management is exhausting. It makes them feel like their body is misbehaving. It's letting them down. It's treacherous. It takes up my whole day, they've said. It becomes who I am. I become a person who is driven, in fact, to manage their pain. That is not good living. What are the other options? Some of you are familiar. Oh no, do be quiet. I don't have time for you to show this. And I apologize. Many of you probably have seen this video. It's available on YouTube. It's called Pain and Me, or if you put my name in, it will come up. It has been viewed more than 160,000 times, and there are more than 1,500 clinicians using this as a clinical tool. And now I'm only hoping that it will allow me to go to the next slide, which it won't. There we go. Okay. This is the idea behind the plasticine video, and feel free to ask me about the plasticine video. The idea that made us develop the intervention I'm just about to talk about. If we can't change the pain, and for many people, we can't actually take the pain completely away, how do we improve mood? And the idea is we can grow the self. We can get ourselves engaged in things that we love doing with people that we love doing them, in order to have a whole load of brain activities going on that have nothing to do with the pain. And I'm going to try and persuade you that this is actually scientific. First of all, we've got a lot of evidence around behavioral activation in depression. We have a lot of evidence showing that if you get people to do things that either they're very good at or give them a lot of pleasure, it decreases their constant thinking about misery. And there is an awful lot of trials around this, both for individuals and in groups, and they are showing pretty good effects, but they are talk therapies. And with pain, there is something that we need to do, which is beyond just sitting there talking about it. And I was really taken with this research from biology. These are animal models long time ago, Grinoff and Black, 1970s, actually, 1980s at most, working with mice and rats. And they were able to show that the mice and rat group that was trained to do new and complex things, actually do acrobatics, and combining motor and sensory things, developed new reward centers in the brain and grew new synapses in areas of the brain above and beyond rats and mice that were just doing physical activity. In other words, doing these things that are maybe a tiny bit hard, but definitely rewarding and new, makes our brain grow new synapses in new places, and these places can overtake the overgrown synapses that are constantly dealing with pain. But patients say, I know I should do more, I know I should get out more, but it's just too intimidating, it's too hard, I'm too tired. And that is where you come in, clinicians in the room. You are an agent for change, not just an agent for bending over and doing squats and lunges and maybe talking about pain. You are an agent to get people to try things that they love doing. And this is absolutely part of your job, in my opinion. No shoulds. The word should is a dirty word and it shouldn't be allowed in the room at all. Oh, I used it. Exploring possibilities that people don't even think they can do, being very flexible about it. Why don't you try this? Why don't you try that? That might not work. Maybe try something completely different. There's no right and wrong. And very much supporting the how, because people living with chronic pain struggle to find solutions and make decisions. So how, yes, I want to engage with that life drawing class that's around the corner, but how do I get there? Your job is to find out how to get there. Which, can they walk there? Is there a bus? Is there a way to get there? Is there somebody else they can go with? These are practical solutions, and it's our job to produce them, to have a conversation about them. This is from the website that we've developed to look at this new intervention called De-Stress, which is all about immersing yourself in things you love doing. And the way that we've structured it to help you as a clinician deal with it is find activities you can do with other people you like being with, but also find activities that you can do at home, because sometimes the pain is so bad that you can't leave home. What can you do at home that you really like doing? Yes, find active activities. This is stuff that we always do, physical activities, but you can also move into that very scary area of creative activities. Have you ever wanted to draw? How about singing? Great for your breathing. Probably will also reduce your pain. And you can develop with every patient their portfolio of things that they like doing, that they love doing, that they're willing to try with your help. Engaging with pleasurable activities is not a soft option. It is a form of pain management. And we are starting to get the data about this being a very effective way of dealing with pain-related distress. In summary, Pain-related distress is a normal response to living with pain. Most of us experience it at least fleetingly. Cognitive processes, the way we process the world around us, can get people into a loop of misery. And our focus on trying to manage the pain above everything else can actually make it worse. When we do enjoyable things, our pain learns new ways of thinking, of being, and of emoting. And that pleasure area and reward center in the brain needs to be exercised just as much as our biceps. We can learn to redefine ourselves amidst our pain when we can't make it go away, and we can become bigger. This is the team that have worked on all of this together and are still working on it, and I look forward to telling you all about clinical trials that try this out. And finally, thank you very, very much for listening. I will stop sharing.
Fantastic, Tamar. Thank you so much. Very, very interesting stuff. There's many nuggets there that I've picked up, which I feel a bit silly for not considering beforehand, but they're so fantastic. Considering the language that we're using, even the word catastrophization, thinking about this impact that it might have on people, and that it's confirmed by people in the chat, that these types of words have results and impact people in a way that we as clinicians and even researchers might not be too familiar with. So thank you for reiterating that. Lots of stuff. I wish we had 2-3 hours for this, but thank you so much for sharing so much time. I would recommend that if anybody hasn't seen the YouTube video, I think it's something fantastic that people can use in clinic. I think it's about 3 or 4 minutes long, and it does a fantastic job at communicating something that I know I found difficult working with people with lived experience of pain. So thank you for sharing that. Okay, so we have just about 10 minutes for some questions. Thank you so much for everybody who's popped them in, and of course the comments as well. We're going to fly straight through them so we can get through as many as possible. Victor and perhaps Pablo might join us as well from the Digi4MSK project. Feel free to share any comments that you guys have as well. So in the Q&A, I'm just going to quickly fly through them because we've had a lot come through. Gafsa has made some fantastic comments about different conditions, and of course affirming your comments there, Tamar, about everything that you've discussed. So Gita says, Tamar, what do we do when they, and I assume they as in people with lived experience, patients perhaps, don't want to engage in referral to talking therapies? How important is talking therapies in this picture of management?
That's a really good question. So broadly speaking, I have come to understand that people don't do what they don't want to do. They just don't. So pushing them won't help. I think asking the questions of why is really important. What is it? Is it a sense that, oh, are you saying this is all in my mind? I get that a lot in my transcripts from patients, that they think that they are being sent to somebody because they are in fact mad, and there is a conversation to be had there. There are always other options. I always think about it as, if you want to climb a hill with somebody living with pain, there are probably several paths up the hill, and your patient will choose the path they want to use most. And for some people, it is physical exercise. For some, it's problem solving. For some, it is creative activity. I guess what I'm saying is don't try and push it because you'll burn out. You'll burn out from trying to push that heavy thing up a hill, and it won't go.
Mm-hmm, mm-hmm. And it just kind of makes me reflect a little bit. And Victor from the Digi4MSK project and the aims of that project, which is to dive a little bit deeper into the thought process of people, why they might understand what they require and how they navigate health, obviously on a much broader perspective. But what's your thoughts about there?
Are you asking Victor or me?
Yeah, so Victor, sorry. Yeah, go ahead, Victor.
I'm sorry. Well, I actually had a question, Nathan, but Could you repeat the question, please?
It's just reflecting on the Digi4MSK resources and the importance of looking past perhaps just accepting someone's opinion, a person with lived experience that they might not want to be referred to talking therapies or some form of intervention. It's looking past that and understanding why they might be making those certain decisions in health. I guess that's what health literacy and communication is all about, right?
Yeah, and this topic lead us to an interesting question. Maybe I'm sure Tamar can give her opinion on this, which is that sometimes knowledge is not, many times it's not enough for prompting behavior change. No, is something necessary, but perhaps not sufficient. No, that's why certain behavior change models emerge, such as the combi, in which there must be some capability, which is where health literacy fits, but also the opportunities, such as having the proper physical environment, but also the motivation. And as she has said, there must be kind of a combination of these factors for people to change their behavior and engage in meaningful activities or something creative and something that requires some challenge, and mainly that is meaningful to them. Because yeah, we have seen clinicians many times recommending swimming to people that have never been swimming, things like that. So what's your thought about the requirements that are necessary for this behavior change?
There's so much stuff flying in the chat that is so interesting. You know, what is required for behavioral change above all else is, and this is just basic building blocks, is motivation and opportunity and capability. Yes, absolutely. But what tends to happen is that and I'm as guilty as anyone else, we think we have an answer. We think we have a right answer. So for example, you might remember, you're probably too young to remember, but do you remember when we talked about passive coping and we thought that praying was a passive coping? I am not a religious person, but what I found out from my research with people with chronic pain is that for them, praying is an active activity. They go to the church, they dance, they sing. It is so uplifting and it is part of their pain control. And for any psychologist to come along and go, don't do that, it's passive coping, it's bad for you, is nonsense. In the same way, was it Annika who had a really interesting question here about, but if they do all these pleasurable activities, creative activities, could it overshadow their physical activities? Let me tell you, looking at people doing these creative activities, have you ever carried a camera across a park? Oh my gosh, it's heavy. You need to walk, you need to bend, you need to stretch. All these things are physical. This idea that there is a right physical and then there's a whole lot of others. I just don't believe it anymore. I think that we just need to engage and move and talk, and that will make us healthier.
But by the way, I would like to ask you something. If you could give Tamar some tips, let me use this word. I know that it will require an entire course and a lot of training, etc. But some tips for those clinicians who might feel overwhelmed by patients with a very, very high pain-related distress. What should they do in order to not feel overwhelmed and deal with patients in this state?
So as you know, I've trained literally thousands now of clinicians exactly in that way. That's why they come to the training. This idea of, I don't even want to go there. I don't want to open that Pandora box. I don't know what to do when a patient bursts out crying. It's not my job to help them with their suicidal thoughts and so on. And it is a very delicate job to increase people's confidence to do what they should be doing and identify the line where it is no longer part of their professional remit. There are a lot of courses around now, so I think people can and hopefully will engage with this. There isn't a trick question. There isn't, I can't do the silver bullet of this is what you do. How do we increase our confidence? What do you do with your friends when they're very upset? I guess you become empathic. I think that empathic responses, honest, integrity-based empathic responses are always the best thing to do, even if they involve saying, I don't know how to help you with this, but I can see you're really suffering.
I think empathy is something that's overlooked often in the management of pain in general. There's lots of stuff coming in. I'm trying to get through as quickly as possible. Did say at the beginning that there'd be lots of stuff coming through, so thank you so much. I just want to chuck in a poll very quickly. I'd love to hear what everybody's thoughts are. So please reflect on your knowledge based on what we've just had, the fantastic presentation from Tamar. So the question is, how is the concept of pain-related distress relevant to your practice? Of course, this is perhaps for the clinicians, maybe even think from a research perspective. Let us know. There should be a poll coming up very, very soon. How is the concept of pain-related distress relevant to your practice? Whilst we do that, apologies if something comes up and blacks the screen, you can't see me, but another question to you, Tamar. Lots of questions, so I'm trying to go for ones which seem to be the most practical and most liked, I guess. So Carl Wong says, in terms of outcome measures, how can we capture pain-related distress rather than using PROMS that was developed to identify clinical depression? You mentioned in your presentation that these tools aren't perhaps the most effective. So what can clinicians do? What's the best way to do this?
In the paper I mentioned, which is coming out in Pain, we used a survey of about 800 people to try and figure out the 3 questions that would allow you to identify it. It is not possible. But what we have done is we've identified one subscale of one measure, which we think is probably a better indication. So again, without going into detail, that will come up there. Oh, I'm glad to see that people think this is relevant. Can I just say something else before we run out of time, because it's so important? Okay. All of this research, certainly the research that has happened in the last 10 years, is not my brain or my mind or even my research team. I work with people living with chronic pain, dozens of them. And over the last 10 years, I can honestly say that as I became a person living with chronic pain, they became experts in helping me with my research.
It's a fantastic comment. It's foundational to everything that we're doing. Of course, that does take us towards the end of the webinar. I'm really sorry we haven't managed to get through, but of course, Tamar, you've done a fantastic job. Victor as well. Looking through, we've seen lots of comments come through, people resonating with the information. I think a lot of those resources are going to be very, very helpful. There's, of course, the Digi4MSK resources, the resources that you shared through your presentation as well, Tamar. So thank you so much. So I think this is going to have to be a good time to bring things to a close. I wish we could go on for another 5 or 6 hours, but such is the modern world. So thank you to everybody who has been involved in the webinar. Of course, everybody here, Tamar, Victor, Pablo in the background, Melinda for helping, of course, Ethic, and everybody from Digi4MSK for helping us with this. As we mentioned at the beginning, this webinar is recorded, so you can access it via the Ethic Academy platform and the Digi4MSK online resources. The YouTube channels, social media, etc., etc. Don't forget. Go ahead, Victor. Go ahead, please.
Sorry, before you close, remember to reply to do the survey. Okay. For us, it's very important. So I think that someone, maybe Pablo or Melinda, has written down the link for the online survey. So we will be very glad if you can fill it. Thank you.
Absolutely. So the link is in the chat there. Very well done, Victor. Thank you for the reminder. Please click on that link and send us some feedback. We rely on this heavily. Ethic do, and of course, any projects that are funded as well. So please click that link and give us some feedback. Let us know how you enjoyed the session today. Of course, share it with your friends. So again, thank you everybody for your questions, your interactions, and contributions as well. We do continue the discussions across on our Discord channel. Please visit the Ethic website to find out more about that if you wish to join us there. And of course, I hope you all have a fantastic day. Please click the link to give us some feedback, and I hope to see you all on the next webinar as well. Thank you very much, guys. Take care.